Dr. Weiss, welcome to Medicine Grand Rounds. It is my truly pleasure to present the Maxwell Mackenzie Endowed Lectureship in Endocrinology. This is one of the main lectureships from the Endocrine Division at the University of Miami and recognizes the contribution of Dr. Mackenzie to the University of Miami and also to thyroid research. Before we get to Dr. Max, let me say a few words about Dr. Mackenzie. He made multiple contributions to clinical and thyroid research, and he was recognized by the discovery of the thyroid-stimulated antibodies as a key component of Graves' disease. Here at the university, he spent 3 decades in different roles as a chief of endocrine, chairman of medicine, and he mentored and developed the career of numerous junior faculty members. He was also recognized as a very caring and compassionate physician by his patients. And in closing, I'd like to thank the Mackenzie family, patients, and members of the division for the generosity to this lecture. And I also want to thank Dr. Stephen Marx for accepting the invitation to deliver this year's lecture. He will be now introduced by Dr. Stephanie Ionao, one of our chief residents.
Thank you, Dr. Burnell. Hi, everyone. Good afternoon. It is my pleasure to introduce Dr. Stephen Marx. Dr. Marx graduated summa cum laude from Yale College, completed his medical school at Johns Hopkins, and subsequently trained in internal medicine and in endocrinology at Massachusetts General Hospital. For 22 years, he was the chief of the genetics and endocrinology section of the National Institute of Diabetes and Digestive and Kidney Diseases. This year, he was appointed as scientific director of genetic disorders at the Firmo Foundation in Florence, Italy. He's published over 400 original articles with research primarily focused on calcium metabolism. He was the first to describe familial hypocalciuric hypercalcemia and has done extensive work to identify multiple genes involved in hereditary and sporadic causes of primary hyperparathyroidism. Dr. Marx's presentation today is entitled Familial Primary Hyperparathyroidism. Please join me in giving Dr. Marx a warm welcome.
Thank you for the introduction. It's truly an honor to give a lecture named after Max Mackenzie, a leader and remarkable scientist who was recognized for the discovery of LATS, L-A-T-S, a long-acting thyroid stimulator, more recently identified as thyroid-stimulating autoantibodies. My talk today is titled Familial Primary Hyperparathyroidism. Next slide. I have no conflict of interest. Next slide. I'd like to begin by talking about the parathyroid gland and primary hyperparathyroidism and the genes that are involved in the parathyroid gland. Next slide. Primary hyperparathyroidism is a common endocrine condition and well recognized and understood throughout the world. The parathyroid gland has basically 2 ways of causing primary hyperparathyroidism. 85% of cases of primary hyperparathyroidism are caused by a single parathyroid adenoma. When this is removed, the disease is cured and does not recur. The remaining 15% of cases are caused by multiple parathyroid tumors, and these can be familial or can be non-familial. Approximately 5 to 10% of the 15% of multi-gland disease are familial. So familial hyperparathyroidism is a relatively common condition among all causes of hyperparathyroidism. Next slide. Just to give a quick overview of what we're going to be talking about, there are 6 distinct categories of familial primary hyperparathyroidism. They are familial hypocalciuric hypercalcemia, neonatal severe primary hyperparathyroidism, multiple endocrine neoplasia type 1 and 4, the hyperparathyroid jaw tumor syndrome, and last, familial isolated hyperparathyroidism, Each of these already has one or more genes identified, and we'll talk about the genes shortly. Next slide. I'd like to begin by talking about familial hypocalciuric hypercalcemia, also abbreviated as FHH. Next slide. The hypercalcemia of FHH has characteristic features. The most important one is the onset at birth. The calcium level in FHH is similar to that in typical primary hyperparathyroidism. However, there's some interesting clustering of serum calcium values according to a kindred. Some kindreds have very high levels, some kindreds have high levels of hypercalcemia. Other clinical features are that the urine calcium is normal despite the presence of a high serum calcium. Similarly, the serum PTH is normal and the parathyroid gland size is normal despite the presence of hypercalcemia. We now know 3 different causes for FHH. These are all present in heterozygous mutations of the calcium sensing receptor, GNA11, and AP2S1. The management is very specific. If these individuals are subjected to a subtotal parathyroidectomy, the disease persists. Therefore, the typical management is watching and not any intervention. I won't spend time talking about it, but there is a possibility of intervention with calcimimetic drugs. FHH is a relatively common cause of hyperparathyroidism. It represents about 4% of all of hyperparathyroidism, with a frequency that is similar to that in MEN1. Next slide. This is a plot of some data from the Scandinavian group in 2007. They plotted the ionized serum calcium in members of kindreds, and they plotted it according to the mutation present in different kindreds. And what you can see is that the ionized calcium values in any given family tend to cluster. Some families have mild hypercalcemia, other families have much more severe hypercalcemia. This is an illustration of the so-called set point of calcium, which is abnormal in FHH. Next slide. Urine calcium in FHH is normal. This is a plot of the urine calcium against the serum calcium in typical primary hyperparathyroidism, outlined by the orange bars, and in FHH. And what you can see is that typical primary hyperparathyroidism tends to have urine calcium which is normal or absolutely elevated. FHH, in contrast, has a urine calcium that is much lower. It is typically in the lower range of normal, and it does have some overlap with the urine calcium values in typical primary hyperparathyroidism. On the average, the urine calcium value is about 1/3 of that in typical primary hyperparathyroidism. Next slide. Serum PTH also is specific for FHH. And this is a plot of the PTH values in different conditions against the serum calcium. And you can see that typical primary hyperparathyroidism has PTHs in the upper right-hand quadrant. FHH tends to have PTH values that are not absolutely elevated, and they are intermediate between those in typical primary hyperparathyroidism and secondary non-parathyroid hypercalcemia. Next slide. We now know of 3 different genes that can cause FHH. The most common cause of FHH is caused by the gene for the calcium sensing receptor, which is a G protein coupled receptor. This causes about 60% of all cases of FHH. Much less frequent is a G protein, so-called GNA11, which accounts for less than 5% of cases of FHH. And an intermediate value is the gene for AP2S1, which is involved in clathrin-coated vesicle trafficking of plasma membrane molecules. This accounts for about 20% of FHH cases. You should note that the tabulation here postulates that about 15% of FHH kindreds are caused by genes that are yet unidentified. And these will be interesting subjects for future research. Next slide. So how do we diagnose FHH? Well, the gold standard is that we have an individual with hypercalcemia and a mutation in one of the known genes for FHH. But recall that we've said that sometimes about 15% or so are caused by genes that are unidentified. So we can have a case of FHH and still a falsely negative gene test. How else do we diagnose FHH? Well, the standard way is by looking for traits in a family. And I've already illustrated the traits that characterize FHH: calcium in a young individual, urine calcium being normal, PTH being normal, and a history of failed parathyroidectomy in the patient and members of the family. This series of complex features basically allows one to make a diagnosis of FHH in a family, not in an individual case, but in a family. There are cases in which we cannot make a decision about whether FHH is present or not. For example, there may be no information about relatives, so we can't call it familial. In cases that the usual way to function is to assume that it is FHH and handle the patient as an FHH case and wait for additional information to arise in the future, maybe new genes, maybe further information about family members. Next slide. Now, what makes FHH so special? How is it that these individuals have lifelong hypercalcemia and normal PTH values? Next slide. Basically, this is a condition in which the secretion of PTH is abnormal. Next slide. This is a very interesting slide. It represents data published in 1985 from the Mayo Clinic. In 1985, they were operating on patients with FHH without knowledge of the special nature of the disease. And this slide is a tabulation of the perioperative course of serum calcium in 14 patients later on recognized to have FHH. And let's just walk through the course of serum calcium in these individuals. Preoperatively, they are hypercalcemic. In the day of surgery and a day or two afterwards, the serum calcium is in the normal range. But by day 7, 1 week after the operation, hypercalcemia has recurred, and it stays constant for years afterwards. Now, we have to think about what's happening in these individuals. It's very informative. These individuals have been operated on by qualified parathyroid surgeons at the Mayo Clinic. And the surgeon has been looking for a parathyroid adenoma and is explored usually to find 4 normal-sized parathyroid glands. The glands may be biopsied, they may be mishandled, they may be ischemic, they may be traumatized. So after surgery, we have an individual with less than the 100% of functioning parathyroid tissue from preoperatively. Maybe 80% of the parathyroid tissue has been devascularized. Despite the fact that the parathyroid tissue is devascularized, this small remnant of parathyroid tissue is sufficient to restore the hypercalcemic state. And this represents the secretory abnormality that is present in the small residual amount of parathyroid tissue. This is not a growth disturbance, this is a secretion disturbance. Next slide. We can think about the control of gland function to be typical for any endocrine gland. The gland meets its stimulus. In the case of the parathyroid, the stimulus is hypocalcemia. And the gland can respond to a typical stimulus in two ways. There can be gland growth, or they can be direct secretion. Normally, we have a combination of the two. Next slide. Now, in MEN1, multiple endocrine neoplasia type 1, we have overgrowth of parathyroid tissue, and we have multiple parathyroid adenomas. This growth process is the main cause of the hypercalcemia in most cases of hormonal overfunction in the parathyroid. Next slide. However, we have these unusual cases in which the glands are not overgrown, but they are able to maintain the hypercalcemia by a secretory process. Next slide. Now, I do want to emphasize that this poor coupling of serum calcium and growth is not only typical of the parathyroid glands. Other endocrine glands can have hyperfunction processes analogous to those in FHH. So, for example, some causes of neonatal nesidioblastosis have normal-sized islet tissue, and yet they have hypoglycemic hyperinsulinemia. Similarly, there are rare causes of primary aldosteronism in which the glomerulosa is normal histologically, but still aldosterone secretion is increased. I won't talk about these other causes in the time remaining. Next slide. We now know that the calcium sensing receptor and it is regulated by agonists that are able to stimulate the receptor. Next slide, please. We can look at the stimulation of the receptor according to a curve of 4 parameters that characterizes the secretory process. If we look at these 4 parameters, the typical feature that we are interested in on the parathyroid is the half maximal of suppression of PTH secretion, the so-called set point. Next slide. The set point of calcium regulation in the parathyroid has a well-identified sequence of molecules that control it. It begins with the calcium sensing receptor, a heterodimer on the outer surface of the molecule. This calcium sensing receptor couples to a G protein called alpha-1, and the G protein couples with other proteins that are involved in a intracellular processing pathway. AB2S1 is part of this process and is involved in recycling of the calcium receptor to the plasma membrane. So in this sequence, we now have 3 molecules that are closely associated with one another that each can cause familial hypocalciuric hypercalcemia. Next slide. We now have drugs which are able to activate the calcium sensing receptor. Cinacalcet is a calcimimetic drug which acts like calcium at the level of the calcium sensing receptor. It is a so-called allosteric ligand at the calcium sensing receptor. Since it acts specifically on this receptor, it is a specific activator on a parathyroid cell, and it inhibits the secretion of PTH. It has been used clinically in uremia, where it's a $1 billion annual market, a real blockbuster drug. It's used in cancerous hyperparathyroidism and also in severe hyperparathyroidism that is not a candidate for parathyroid surgery. It's worth mentioning that it has no effect on the secretion of PTH-related protein, which is a molecule that is secreted by non-parathyroid cells. Next slide. I'd like to talk now a little bit about neonatal severe primary hyperparathyroidism. Next slide. This is a disease of neonates, as the title states, and respiratory distress is the most striking feature. The respiratory distress has several causes, but softened bones is a big feature in these diseases. They have rib fractures and they have a bell-shaped chest. They also have hypotonia that is caused by high PTH and high serum calcium. The serum calciums in the neonate include a very high PTH and a high calcium. Some neonates that have a heterozygous receptor abnormality have a moderately high calcium, a homozygous abnormality is associated with extremely high serum calcium. The management is for 4 big glands. If there is a homozygous process, there's a need for emergency total parathyroidectomy. If it's a heterozygous process, sometimes the parathyroid overactivity is reversible and can be monitored without active intervention. The cause, as I've implied, is either a single or a double copy mutation of the calcium sensing receptor. Next slide. This is an example of the bell-shaped chest shown on the upper panel, and information that such an abnormality is sometimes reversible, and that same child, after intensive medical therapy, has a normal-shaped chest. Next slide. So I've already mentioned that this can be caused by 1 copy of the receptor being abnormal or 2 copies being abnormal. If there is 1 copy that is abnormal, the intrauterine fetus senses the maternal serum calcium as insufficient, and a secondary hyperparathyroid process develops in the so-called heterozygote. The heterozygotes have a serum calcium level that is not as high as in homozygotes, and similarly, serum PTH is not as high in the heterozygotes as in the homozygotes. The heterozygous state is associated with a maternal placental calcium deficiency. This is not associated in the homozygotes. Next slide. This is a plot of the serum calcium against the serum PTH in severely affected neonates. And what you can see is in the red symbols are individuals with a homozygous mutation, that is to say both copies are mutated. The maximal serum calcium is extremely high. Individuals who have a lower serum calcium very often just have 1 copy that is mutated. And these 2 groups can basically separate out individuals with a mutated homozygous copy of the receptor on the basis of the serum calcium, so that we can actually make a diagnosis of the homozygous state of neonatal severe hyperparathyroidism based on the serum calcium alone. This is very important because it means that we can have a guideline during life before even we know about the genetic basis of the disease. Next slide. So in a typical FHH kindred, hypercalcemia is about 95% specific for diagnosis of the heterozygous carrier. In the severely ill neonate with a hyperparathyroid bone disease, extreme hypercalcemia is about 99% specific for diagnosis of the homozygote. Next slide. So serum calcium becomes a gene test in FHH. In a family, measuring the serum calcium alone can be a specific test for the disease. In severely affected neonates, measuring the serum calcium can be a test for the homozygous state. This is analogous to other chemical and laboratory parameters which can be used to supplant or replace gene testing in certain syndromes. Another example would be calcitonin testing in MEN2. Next slide. I'd like to talk for a few minutes now about MEN1, which is a model for tumor production in the parathyroid gland. Next slide. MEN1 is well recognized, and I think this is a disease that everybody in the audience already is familiar with. It's associated with the 3 Ps, tumors of the pituitary, parathyroid, and pancreaticoduodenal tissue. It's also associated with tumors in the foregut neuroectoderm, but these are somewhat less common, and so they are not usually listed as characterizing features of the disease. Next slide. When the MEN1 gene was identified, it was quickly made clear that this gene is mutated in about a third of sporadic parathyroid tumors. It's also mutated in a third of bronchial carcinoids, a third of sporadic gastrinomas, a third of insulinomas, and a third of neuroendocrine islet tumors. So this was a great discovery, which gave us some insight into causes of common endocrine diseases. Next slide. I'd like to just briefly compare the clinical features of 2 types of primary hyperparathyroidism that we've already mentioned. A proliferation defect, which is MEN1, and the calcium sensing receptor defect, which is FHH. MEN1 has a high calcium value that is delayed after birth. Typically, the hyperparathyroidism in MEN1 begins around age 20. This is in contrast to the hypercalcemia in FHH, which begins at birth. MEN1 is associated with monoclonal tumors. FHH is not associated with monoclonal tumors. Subtotal removal of the tumors can cause a lasting remission of the disease in MEN1. It has no benefit in FHH. Lastly, endocrine cancer is associated with the growth disturbance in MEN1, and endocrine cancer is not associated with FHH or the neonatal severe hyperparathyroidism. Next slide. So I'd like to briefly talk about the special features of MEN1 according to the specific tissues. Next slide. Parathyroid in MEN1 has features that are different from the parathyroid in typical parathyroid adenoma. The onset is earlier. As I said, the typical onset of hyperparathyroidism in MEN1 is around age 20. This contrasts with an onset age of around 50 in typical parathyroid adenoma. Because of the earlier onset, the individual with MEN1 is at risk for osteoporosis at an earlier age, and this is recognized sometimes in the 30s in individuals with MEN1. MEN1 is more frequently associated with a negative result of surgery than typical parathyroid adenoma. The fact that there are 4 different tumors means the likelihood of an abnormal location is 4 times as common as an individual with a parathyroid adenoma. Lastly, the disease in MEN1 can recur 10 years after surgery. About 50% of MEN1 cases have a recurrence of primary hyperparathyroidism about 10 years after parathyroidectomy. This is not seen after surgery of a parathyroid adenoma. Next slide. So to summarize, we can characterize the features of MEN1 tumors that are different from sporadic tumors. The first feature that is unique is the multiplicity. MEN1 has multiple tissues, the insulin tissues, the bronchial carcinoid tissues. In addition to that, the specific features of the disease can differ and be specific for MEN1. So for example, in the case of the parathyroid, we've already said that the disease begins at an earlier age than in typical parathyroid adenoma. In the case of the pituitary gland, the glands are larger in MEN1 than in typical sporadic pituitary disease. And lastly, in carcinoid tissue, the location is strikingly different. The carcinoid tumor of MEN1 is mostly in the bronchus or in the mediastinum, as opposed to sporadic carcinoid tumors, which are in the large bowel or the jejunum and ileum. Next slide. This is a slide of an operation for an individual with Zollinger-Ellison syndrome. And it's a panel showing the duodenal mucosa. And you can see in this mucosa the little dark areas that are microgastinomas. And you can see on this slide that there are already 5 or so microgastinomas in this small region of tissue. And this warns one to the fact that an individual with MEN1 can have 30 microgastinomas spread throughout the duodenum and basically not amenable to a surgical approach. Next slide. Next slide. Now, multiplicity is a feature of the endocrine tumors in MEN1. It's also a feature of non-endocrine tumors. Just go back a slide, please. MEN1 patients have facial angiofibromas about 90% of the time. They have truncal collagenomas about 70% of the time. They have lipomas about 1/3 of the time. And women with MEN1 have an increased frequency of leiomyomas. Meningioma is also a silent feature of MEN1 in about 5% of cases. Next slide. This is a typical angiofibroma in an MEN1 patient. This is a rather severe example that is not always seen. It's an acneiform lesion, which typically does not go away. It comes and it stays present indefinitely. Next slide. Here is a more typical presentation of angiofibromas, small acneiform tumors around the nose, and you'll see scars where the individual has dug out an old angiofibroma. Next slide. This is a severe example of a truncal collagenoma. These pedunculated polyps are more severe than you will see in a typical MEN1 patient. Next slide. This is a typical feature of a truncal collagenoma. It's a flat papule, slightly elevated, as you can see from the shadow that it's casting. And it's a lesion which is very easy to overlook and not see. The arrows highlight several of these lesions, and there are additional ones that are not shown with the arrows. Next slide. Now, we've spoken about all the benign tumors in MEN1, but MEN1 is a cancer syndrome. Next slide. About 25% of patients with MEN1 will die of an MEN1-related cancer. Next slide. Now, the cancers in MEN1 are present in locations that are difficult to approach surgically. So, for example, the foregut carcinoid includes cancers of the thymus, the bronchus, and the stomach. And the enteropancreatic tissue includes gastrinomas of the stomach, the duodenum, and other enteropancreatic tissues. All of these tumors are in so-called bad locations and represent a problem for MEN1 patients. Next slide. The tumors that we've talked about have some we have a family with MEN1. Next slide. Next slide. If we have a family with MEN1, sometimes the tumors alone can be used for diagnosing the disease. Go back one slide, please. Back one slide, yes. In MEN1, angiofibromas and collagenomas can be used for diagnosing an asymptomatic member of the family. Similarly, calcium and PTH values are useful in screening from time to time. Next slide. When we talk about screening in MEN1, usually what we're really talking about is an individual who is a known carrier for a tumor either to be present in the basal state or to emerge during follow-up. And this table shows that we have an algorithm for screening for the various tumors in MEN1. And the screening has to be done according to patient age, specific testing, and sometimes by imaging methods. So for example, in the parathyroid, we recommend to begin screening for hyperparathyroidism with calcium and PTH at the age of 8. Castrinoma occurs later on, and so we only recommend screening beginning at age 20. Other enteropancreatic tumors do not secrete hormones that are actively recognizable and may not be diagnosed by screening for a hormone. Pancreatic peptide and neuroendocrine peptides are not good tests for screening, and thus, therefore, the enteropancreatic tumors have to be screened periodically by imaging tests. Next slide. I'd like to talk briefly about the cyclin-dependent kinase inhibitors, which are causes for occasional cases of MEN1 and are so-called MEN4. Next slide. This is the plot of the pathway for cyclin-dependent kinase inhibitors. It begins with the retinoblastoma protein, which is activated by phosphorylation. Phosphorylation of the RB protein leads to a cell growth state. Retinoblastoma protein is phosphorylated by cyclin-dependent kinases, and these are activated by cyclin molecules that are specific to the cell cycle. There are 7 individual cyclin-dependent kinase inhibitors, and they fall into 2 families, the P27 family and the INK4 family. Next slide. We'll talk briefly about P27 now. About 15 years ago, let's try this slide, a group in Chapel Hill recognized a very unusual engineering mouse. They knocked out the P27 and P18 molecules and observed mice that had a combination of tumors characteristic of MEN1 and tumors characteristic of MEN2. This was a very puzzling observation and went without an explanation for several years. Next slide. Next slide. Approximately 10 years later, a group in Munich identified a rat, free living rat molecule, sorry, back, one slide back. A rat that had the same syndromes as the P27, P18 knockout. This rat was then characterized in the laboratory as having a homozygous deletion of P27. Based on the fact that the Munich group now had evidence in both the mouse and the rat for P27 abnormality causing this MEN1 and MEN2 syndrome, they screened some human kindreds with MEN1 and no known mutation of the MEN1 gene. They identified one family that had a P27 mutation that tracked with the disease. And this was the first example of so-called MEN4 caused by heterozygous inactivation of P27. Next slide. We tried to explore this further in a study by Sunita Agarwal, in which she looked at all of our patients collected over a 10-year period that had been referred as possible MEN1 and did not have MEN1 mutations. This was 196 cases of rule-out MEN1 without MEN1 mutation. She screened all of the 7 CDKI genes for mutations and found mutations in 4 of the 7 CDKI genes. P27 was the commonest, but there were occasional mutations in P21, P15, and P18. Now, this is a small fraction of all cases of MEN1, maybe 1% of all MEN1 cases, but it's a phenotype that looks like MEN1 or familial hyperparathyroidism. Next slide. We don't have very many families with MEN4. This is a very large family that was reported in the JCENM 2 years ago. This kindred had some 13 carriers of a P27 mutation, and they compared them to some 29 cases in a current literature review. What is evident is that in this large family, 25% of cases have pituitary tumor, and neuroendocrine tumors are about 17%. So it suggests that MEN4 may have more pituitary tumors than gastrinomas, but we need more cases to really characterize this novel syndrome. Next slide. So how do we get tumors in MEN1? What does MEN1 mutation do to cause tumors? We don't understand the MEN1 mutation pathway. And this is an illustration of a large team of scientists that we worked with back in 1997 to identify the MEN1 gene. Francis Collins and Alan Spiegel get a lot of credit for putting this group together. Next slide. Current work on the crystal structure of menin, the protein encoded by the MEN1 gene, suggests a large flat zone which could interact with JUN-D or MLL1 proteins. I won't describe the laboratory evidence that JUN-D and MLL1 are downstream molecules in the pathway of menin. Next slide. But basically, the hypothesis, which is unproven to date, is that menin protein binds to MLL complex, a complex that binds to the transcription zone of the cyclin-dependent protein kinase inhibitor. Thereby, menin and the complex can stimulate the release of cyclin-dependent kinase inhibitors, which are the tumor suppressors that can be downstream molecules in the menin pathway. Next slide. I'm not going to talk at length about MEN2A, the so-called medullary thyroid carcinoma syndrome. Next slide. It's well understood and well recognized. It causes parathyroid tumors, but more frequently, medullary thyroid cancer and pheochromocytoma. Next slide. This is an illustration of the thyroid gland in MEN2A provided by Sam Wells from a patient that had a total thyroidectomy. And you can see that in the upper third of the thyroid gland, there are multiple nodules, multiple medullary thyroid cancers. So this is a disease which is very striking in its occurrence within the thyroid gland. Next slide. We've now learned over the years that screening and management is very different in MEN2A and MEN1. Both of these syndromes can cause a lethal cancer, and both of them can be diagnosed in the germline. And the germline diagnosis is useful in making plans. However, in the case of MEN2A, it's possible to remove the host organ of the cancer, the thyroid gland. We cannot do this in MEN1. We can replace the host organ by giving thyroid medications very easily. We don't have easy replacements for the glands involved in MEN1. Thus, we can prevent cancer in MEN2, but we can't prevent it in MEN1, and we can even cure cancer in MEN2, but not in MEN1. Next slide. I'd like to talk now about the hyperparathyroid jaw tumor syndrome, so-called HPT-JT. Next slide. This is a disease that causes primary hyperparathyroidism in 80% of affected individuals. However, of the individuals with hyperparathyroidism in this syndrome, 15 out of 80 have a parathyroid cancer. They also have jaw tumors, they get multiple renal cysts, and the women get uterine tumors of rather poor characterization. It raises a question about how aggressive one should be about treating hyperparathyroidism in this syndrome. In the case of MEN2, we can remove the host organ and basically have a cure. Should we be doing total parathyroidectomy in the jaw tumor syndrome? I won't take the time, but we think that it's better to manage these people conservatively and look for the occurrence of hyperparathyroidism and operate on the parathyroids when they overexpress parathyroid hormone. This is caused by a point mutation in the CDC73 gene. Next slide. This is a boy that has a prominent right cheek. You can see that there is a tumor in the maxillary sinus, also in the horizontal CT. This is a benign tumor, so-called cemento-ossifying fibroma. And the histology is important in that it is distinct from the parathyroid tumor of hyperparathyroidism, in that this tumor does not have a predominance of osteoclasts. Next slide. I neglected to mention that this boy has the jaw tumor, but he does not have hyperparathyroidism. His brother died of a parathyroid cancer, and this just illustrates the fact that the jaw tumor is independent of hyperparathyroidism. The parathyroid gland in this syndrome tends to be cystic and can have multiple large cystic tumors of the parathyroid. Next slide. There's also a microscopic cystic appearance in the parathyroid tumor of the jaw tumor syndrome. Next slide. I don't see the slide at full scale. Can we enlarge it? Next slide. The jaw tumor syndrome, back one slide, please. Jaw tumor syndrome has some very interesting features of the CDC73 gene. Turns out that about 70% of sporadic parathyroid cancers have a biallelic mutation of the CDC73 gene. Many of these cases have an occult germline mutation of the CDC73 gene. And this means that when you're dealing with what seems to be a sporadic parathyroid cancer, there is a reasonable possibility of a germline mutation and any case of sporadic parathyroid cancer needs to be screened for CDC 373 mutation. Next slide. I'd like to finish by talking about familial isolated hyperparathyroidism, so-called FIH. This is a diagram to illustrate the problem in identifying familial isolated hyperparathyroidism. It can be an expression of many different causes of hyperparathyroidism. So if we have a population of patients with familial isolated hyperparathyroidism, some of them have MEN1, some have the jaw tumor syndrome, some are sporadic, and some actually have FHH. Next slide. We can use our clinical tools to separate out, as well as possible, the so-called pure FIH. Next slide. Pure FIH is a rarely studied disease. Typically, there are only 2 affected cases in a family. And since it's such a small family, it's hard to identify how frequent it is. Our own series of cases leads us to believe that the frequency of FIH is about 1/5 the frequency of MEN1 and FHH. The average age of diagnosis is around 55 years old, and there is a predominance of Ashkenazi Jewish families, which we don't understand. This is a disease of parathyroid tumors. It's a parathyroid growth syndrome, and they have multiple large parathyroid tumors similar to those in MEN1. Of course, it's always important to exclude phenocopies, the incomplete forms of MEN1, etc. Recently, our group identified a mutation in the GCM2 gene in 17% of cases of FIH. Next slide. Next slide. Next slide. GCM2 is a gene that had previously been identified in hypoparathyroidism. It has a DNA binding domain, and mutations in the DNA binding domain cause familial isolated hypoparathyroidism. There's a conservative domain here towards the C-terminus mutated to cause familial isolated hyperparathyroidism. Next slide. So this GCM2 is mutated in about 17% of FIH cases, and that leaves the remaining 83% of FIH cases with an unknown gene mutation. And these unknown cases of FIH represent a large area of research for my own group. Just to summarize what we have gone over, the surgical approach is different in the different forms of familial hyperparathyroidism. So the severely affected neonate has 4 enlarged glands, and depending on whether it's the homozygous state, the approach would be a total parathyroidectomy. MEN1, 2A, and familial isolated hyperparathyroidism has 3 to 4 asymmetric enlarged glands, and the typical surgical approach is the removal of 3.5 glands. The jaw tumor syndrome, typically there's one gland much more affected than others, and in particular parathyroid cancer. And the recommended operation is a parathyroid cancer operation, and often the remaining glands can be left alone. FHH is distinct from these other diseases in that all 4 parathyroid glands are normal, and hopefully the surgeon won't even be operating on the FHH case. Next slide. Next slide. We've learned from studying familial primary hyperparathyroidism that identifying genes has given us some surprising benefits for each of the different diseases. So for example, in the case of FHH and the neonatal severe disease, we have developed calcimimetic drugs, which are very useful agents outside of the disease of FHH. MEN1 has told us about a key to the occurrence of sporadic endocrine tumors. And when we have a fuller understanding of the MEN1 pathway, we expect that we'll have some interesting interventions in sporadic endocrine tumors. MEN2A has been another unique story and has given us information about cure of cancer. Tumor syndrome has given us information about sporadic parathyroid cancer and the fact that sometimes we have to think about hereditary disease, even though it looks like a sporadic disease. FIH is also interesting in that this rare disease is keying us in to some 87% of cases where there are different genes that are the cause of the syndrome. Next slide. To summarize now, there are 6 hereditary hyperparathyroid syndromes. Most of them are neoplasms with parathyroid overgrowth. Familial hypocalciuric hypercalcemia shows mainly oversecretion within the parathyroid gland. Familial isolated hyperparathyroidism has told us a recent role for the identification of GCM2. We now understand that the surgery for familial hyperparathyroidism can be personalized in that the different syndromes have different approaches to surgery. Parathyroid cancer in the jaw tumor syndrome very often is hereditary. So each of these hereditary syndromes has given us some selected benefits for studying them in detail. Thank you very much.
Thank you, Dr. Marx, for an absolutely superb review and presentation and insights. Makes me proud to be an endocrinologist and makes me understand why I went into endocrinology. Because we're at the top of the hour, I'm afraid we don't have time for questions, but there are a few questions in the chat that we'll be sure to forward to you. I wish everybody a good day, and thank you so much again, Dr. Marx, for visiting us in Miami. I hope we get to see you physically here in the very near future. Thank you all. Have a
Thank you, Dr. Marx.
Okay, my pleasure.